Healthcare providers face tremendous costs in responding to COVID-19. At the same time, they've lost significant revenue due to the postponement of elective procedures. This is Carolyn Lowell with OrthoWorld. Joining me today is Dr. Peter Althausen. Dr. Althausen is an orthopedic trauma surgeon in Reno, Nevada, and chairman of the Orthopedic Implant Company, or OIC, a value-based device company that primarily serves the trauma market with a repless model. Two themes emerged from our discussion about the current environment. One, the transition of orthopedic procedures to outpatient settings, and two, the need for providers and surgeons to become more cost-conscious about implant utilization. We started the conversation by talking about his experience as a trauma surgeon today.
Well, it's been pretty interesting. In the trauma world, our work has gone down slightly just because there's less people on the road. But at least in Reno, there are still businesses open like construction, which always create injury. There are unfortunately a lot of people doing home projects who haven't used power tools for a long time. So we're getting a lot of injuries based on that. And simply a lot of folks who are older are still falling and getting hip fractures and that kind of thing. So the hardest part about it has actually been managing getting those people treated. So people that have traumatic injuries like falling from a scaffold or getting in a car wreck, those are still going to the hospital. But we also have another proportion of people that are trying to avoid the hospital that have isolated orthopedic injuries, like a wrist fracture or an ankle fracture. And what is happening now is those patients are coming to our office. I'm a private practice orthopedic surgeon, and we have urgent cares that we've created that are dedicated musculoskeletal urgent cares with an attached ambulatory surgery center. So the good thing about that is you're taking healthy people with a broken arm or leg. You can bring them right into the office, avoid the emergency room where people are being treated for COVID potentially, and then brought upstairs to our surgery center. And all of our patients, we're screening them just like hospitals, but it is actually changing a model of care from, expensive hospital care with exposure to a more directed orthopedic line of care.
What has been OIC's experience during COVID-19?
So as far as work in the hospitals, our work has not changed very much. We are in about 50 hospitals across the country and some large IDNs like Intermountain Healthcare. And those savings have continued to occur for them. Where we have seen a big change is in ambulatory surgery center business. And doctors now, realizing the cost of care, are starting to be more cost conscious of their implant utilization. Now, the reason for that is that the industry, once again, is intertwined with business and insurance companies that makes decisions difficult. For us, we try to make things, at least in my office, as separate from OIC, a very clear delineation of how we choose to use implants. Many insurance companies have an arrangement with surgery centers that is called cost plus. So they get paid the cost of the implant used plus like 10%. So in a twisted fashion, you're actually incentivized to use the most expensive implant because you're going to get 10% more on that. So many implant companies will try to sell things to our surgery center saying, hey, use us, we're the most expensive. You're actually going to make more money on the back end. And we say, hey, that's immoral. These are patients we need to take care of. And many people now with COVID have lost their jobs. They don't have health insurance. They're doing home projects or home businesses, and they want to get taken care of well, so they don't have complications, but also in the least expensive way possible. So what we have found now is that people are asking, what is the cost of the implant? Surgeons are asking, what's the cost of the implant? Patients are asking, what's the cost of the implant? And so what's happening now, because the hospitals are overwhelmed with COVID patients, the patients that didn't used to go to ambulatory surgery centers who are underinsured or uninsured, like Medicaid or Medicare patients or uninsured private pay patients, they're now coming to our surgery center for care. And now the cost of the procedure is apparent and it is put on the surgeons. And so now we are able to help assist in the whole healthcare crisis by lowering the cost of care while providing good care.
How is OIC preparing for the return of elective procedures?
So our focus primarily is on trauma products. And we have done a few things. We know that um, there is going to be probably an uptick in trauma care, of course, because as people go back to work, even in more and more droves, there's going to be more car accidents. That's how it works. Um,
Yeah,
so we are, increasing our production and our levels so that we can support the contracts that we have and the hospitals that we have. Ideally, we are also approaching other physician groups and ambulatory surgery centers and letting them know once again that, using our implants is a 60% cost savings in general across the United States. For any business that's in trouble, for giant practices like ours, or other ones that have, 300 to 400 employees, where, you're potentially furloughing people or not letting people get back to work, those businesses have to get up and running.
sure.
And if you're gonna now operate a surgery center 7 days a week instead of 5 to take care of a huge elective case backload, um, you're going to have to be able to do that efficiently. So we are really getting out there and letting people know that one of the ways to recover these lost revenues over the last 2 months is to really pay attention to your costs in your surgery centers.
Mm.
And for hospitals as well, hospitals who have borne the brunt of the COVID expenses, they should be more concerned than anyone about operative costs.
I mean, to your point, COVID-19 will undoubtedly reshape orthopedics, I think, in many ways. What other trends do you see emerging for the industry, for surgeons?
So I think the first is probably going to be more of a transition to outpatient care, to trying to keep people out of hospitals. I see hospitals that do not have their own ambulatory surgery centers partnering with private physician groups that have them, because care really has to be more efficient. And hospitals are big systems, they're very hard to change, whereas smaller surgery centers, their physician groups are nimble. And I think when you're looking for high value, that is, the goal of that is efficiency with quality, essentially. And so if you can partner with the people who do those things the best, you're going to have the best system. And so I think a lot of those trends are going to happen. I also see a lot more outpatient blocks and anesthesia techniques that let people have procedures that used to have to be done in hospitals now able to be done at outpatient surgery centers, and we're seeing that already, like tibial plateau fractures and tibial pilon fractures. Total joint replacements now, for instance, are almost all outpatient if a patient is healthy, and that has massive, massive savings. I do also see hopefully more of a transition towards arrangements between healthcare companies and hospitals and physicians with regard to gain sharing and co-management. And those are two very important terms that physicians really don't understand so well. So gain sharing basically means if I save you $100, you keep 90 bucks and I get 10. Co-management means you take an entire service line, like all of orthopedics, and say that's $30 million. And they would have the doctors help manage that with their expertise for a hospital for a percentage of that. Why those two things are important is that doctors work a lot. I mean, we have, like I work 80 to 100 hours a week, and I have for the last 15, 20 years. So if I have extra jobs to do or have to change an implant that I use or change a protocol that I use, it is hard. And to develop those protocols is time consuming. So it has always been hard to incentivize doctors to use cheaper implants or cheaper protocols for that reason. And if you use a program like gain sharing or co-management, the doctor is incentivized to look at the cost of things and look at his outcomes or her outcomes and figure out the best plan of care. And so with this, I don't know if you know what BPCI is. but it's the Bundled Care for Payment Improvement Project. And that on the website for CMS, the Center for Medicaid and Medicare Services, it says this is the first legalized program of gain sharing in the country. And what it did was incentivize over the last 7 years physicians to make those kind of choices. And my office has been involved in those in both the hip fracture protocols, which OIC has been very successful for, and for the total joint protocols. And that hopefully will be a model for success for other areas of orthopedics. And I think, as you mentioned before, with COVID, the extreme cost and a change essentially in healthcare delivery in America is going to go more this route, because we're going to have to get physicians on board to help control costs. You can't have a system that we have now where doctors can just use whatever implant they want for whatever price they want and not care how much it costs, because then there's no price control.
Interesting times ahead of us.
It is very interesting, and I love change. I think most trauma doctors love interesting scenarios, and this is not a trauma to a patient, but it's a trauma to a nation and a healthcare system. And it's a very interesting problem to try to think through. And I think there's a lot of smart people out there that if they put their brains to it, we could develop a more efficient, a more high value, a more high quality, and a better system to take care of the massive numbers of patients in America.
I appreciate your time today. Is there anything else you would add?
No, I was enjoyable talking to you. Thank you so much.
Yeah, you as well. Thank you.
Have a great
Okay,
day.
so, you too. Bye.